All right, so today we're going to be talking about cranio-vertebral junction injuries, classifications, and management. This is a particularly good topic because a lot of the information here is going to be particularly involving the classification. There's not much for treatment, but classification, by and large, is highly asked about, good things to know about, and can be helpful for differentiating some of the indications for treatment for these patients. So, to start off, just as a little bit of background here, when we talk about the craniovertebral junction, we're talking about the most mobile portion of the spine. It's formed by three main bony structures, the occiput and then C1 and C2, respectively referred to as atlas and axis. And one of the most important structural components of the craniovertebral junction is going to be the ligamentous sling that really envelops these bony structures and gives them stability under lots of physiologic load. In general, when we talk about the ligamentous anatomy of the craniovertebral junction, we're talking about intrinsic and extrinsic ligaments. The intrinsic ligaments provide most of the stability of this region. The particular intrinsic ligaments are going to be the tectorial membrane, the cruciate ligament, the odontoid ligaments, and the anterior atlanto-occipital membrane. The tectorial membrane is an upward extension of the posterior longitudinal ligament from C2 to the anterior aspect of the foramen magnum. The cruciate ligaments are cross-like structure behind the dens. Cruciate typically meaning cross. Transverse part is inserted bilaterally on the medial portion of the C1 lateral masses. The vertical part of this cruciate ligament is going to attach the C2 body to the anterior portion of the foramen magnum. The odontoid ligaments are twofold, composed of the alar and the apical ligaments. The apical ligaments, apical meaning apices on top, are going to attach from the tip of the dens to the anterior portion of the foramen magnum. The paired alar ligaments run from the posterior upper third of the odontoid process to the lateral masses C1, and the medial borders of the occipital condyles. Extrinsic ligaments include ligament of flavum, which is located between the atlas and axis, ligament of Nuchae, and the fibroelastic membranes, which anteriorly replace the anterior longitudinal ligament. Here's an excellent diagram from Human and Wynn that really goes over these structures we just talked about here. In picture A is going to be the C2, also known as the atlas vertebrae. As you can see, here's that all-important transverse ligament, which is going to be crucial when we talk about fractures, isolated fractures of C1. The tectorial membrane sitting posteriorly to that transverse ligament, again, is better shown in panel B here, where we can kind of see it divided up here as it kind of comes up alongside of the foramen magnum anteriorly. If we do move down inferiorly, we see the ascending band and the descending band of that cross-like cruciate ligament. Here's the transverse bands as they attach laterally over here to the C1 lateral masses. And then just anteriorly to this cruciate ligament here, we can start to kind of appreciate, here would be a little bit of the outline of the odontoid process, also known as the dens, and then the left alar ligament here, coming from the tip of that dens out laterally to the foramen magnum. This is a really good picture, kind of probably one of the best pictures you'll see on this ligamentous anatomy out there to date. All right, so when we talk about dissociation of the craniovertebral junction, one of the most frequent things we want to talk about is occipital-atlantal dislocation. How does this happen? Well, typically with most cervical spine trauma in general, it's going to be high-speed motor vehicle crashes, pedestrian strikes by motor vehicles. And actually, when you look at autopsy series and those who have died from craniovertebral junction dissociation, you see the majority of these are the result of a motor vehicle collision. So high-velocity trauma is going to be one of our major precipitants of dissociation of these craniovertebral junction. One of the things to consider, particularly in patients that have occipital condyle or occipital-atlanto dissociation, is that running in that foramen magnum is going to be jugular foramen, the hypoglossal canal containing cranial nerve 12, jugular foramen's going to have 9, 10, and 11 in it. So, patients coming in following this high velocity trauma with palsies in these lower cranial nerves, 9, 10, 11, and 12. This is certainly something to consider. Another kind of physiologic phenomenon that you may see is what's called cruciate paralysis, which is weakness of the hands and arms with relative sparing of the leg strength. Um, this is not an uncommon manifestation, and a lot of times this can be one of the clues into these cranio-vertebral junction dissociations. This right here is, you know, initially back in the day, they used to look at these lateral radiographs, and they developed all these measurements to essentially to give reference to, what were the parameters that would demonstrate if someone had, an intact occipital-lanal joint. And they decided, through various studies that, values above or below these would indicate injury to these regions. And what I have shown here, again, is another picture from Humans and Wynn. And this really demonstrates kind of the main measurements that you'll see. The Powers ratio in particular is one that is still used to this day. And, if you're going to get asked about one on rotations, as a neurosurgery clerkship student or as a sub-intern, this is one you'd be asked about probably. X lines, this is one that was used, the Wholey method, however you want to pronounce that. The condyle, the C1 interval, and then Harris lines. Right, so let's quickly go over these and what they are. Usually kind of pretty self-explanatory. One of the major things to know is a lot of these are based on the basion, the opistheon, right? So if we look at the here's kind of the clivus as it moves inferiorly. Right here would be the basion at the lowercase a. Here would be opistheon here at the lowercase d. Right, so these are going to be two critical bony landmarks to know, not just for cranio-vertebral junction, but also when you talk about the McRae line and Chiari malformations, knowing where the basion and the opistheon respectively are located is very important in delineating what those measurements are. Okay, and then a couple other key things you want to look at, right? So looking here sagittally, we've got the C2, right? Here's the dens, the C2, here C1 and anterior arch, posterior arch. All right, here would be the canal. This would be the C2 spinous process, right? So these are just kind of your baseline ballpark bony landmarks you need to understand to make these measurements effectively. All right, so we'll just talk about the Wholey method first, right? So really, what we're looking at here is essentially we're going from the basion to the dens to the apex of the dens, and we're looking at the basion to the dentine angle. And what they say is displacement more than 10 millimeters is going to be considered abnormal. Move over to the Powers ratio. Again, this one is a great number to know. I would really lock this one away. The basion right here to the posterior atlas arch divided by the opistheon to anterior atlas arch. A ratio greater than 1 is considered abnormal, right? So 1 is a very easy number to remember. So if there's one, I would say commit to method. This would be the one to do so. Now when we look at the X lines, right? So this was described by Lee et al. Failure of a line from the basion to the axis spinolaminar junction, right? So basion to axis, right? C2 spinolaminar junction, and then we're going to look at the opistheon right down here to the dens, and so essentially, failure of a line from the opistheon to the posterior inferior corner of the body of the axis to intersect C1, right? So here would be the anterior arch and the posterior arch, right? Failure of that to go through that C1, that kind of that imaginary line right there, would be considered abnormal. Harris lines is, to me, one of the more complicated ones. Again, we're using the basion, the apex of the dens, so it's kind of an adaptation of this Wholey method over here, but with the addition of the posterior inferior corner of the dens, right? So what they say here is displacement more than 12 millimeters posterior or less than 4 millimeters anterior between the basion and posterior C2 line, aka the basion atlas axis interval, right? So this value right here, or this value right here, or displacement more than 12 millimeters from the basion to the basion dens interval, right? So this one right here is considered abnormal. All right, so those are just some ballpark measurements. Again, the powers ratio by far is the one I would commit to most to memory. A lot of this was based on lateral radiographs, and while lateral radiographs do inform bony anatomy, fractures, and some decision making around fractures of cervical junction, by and large, CT is going to be the gold standard for delineating these injuries, and therefore some of these measurements are either abandoned or adapted to CT imaging. But these are good historical things that you will be asked about at some point in time during your neurosurgical training. All right, so really the meat of this lecture again is going to be when we talk about these classifications, right? So 1986, Trainalis and Associates proposed classification. 3 types of OAD based on displacement of the occiput over the atlas. Again, atlas means C1. Type 1 describes anterior displacement of the occiput relative to the atlas. Type 2 is a distraction injury with vertical displacement of the occiput. Finally, type 3 involves posterior displacement of the occiput. Lateral rotational and multi-directional dislocations cannot be classified using the system and could be considered as other types. The nice thing about these cranio-vertebral junction injuries is that they are all essentially types 1, 2, and 3s. So it kind of is, you can kind of keep these things in mind here. So right here, this slide just shows you the words. You go here, this is a great picture. All these pictures are coming from Human and Wynn. I think most of these were, you look down here at the bottom right-hand corner, most of these were illustrations done at the Barrow Neurological Institute. So it's pretty simple classification if you look at it again right here. Kind of we have the clivus come down to the basion. Posteriorly, we're looking at the occipital bone. Come down here, the opistheon. Here's the occipital condyle. Here's the anterior arch of C1. Looking at the posterior arch of C1. Here's the C2. All right, central canal. And so we just have an anterior displacement of the occiput over on C1, right? And then here in type 2, we just have this vertical upward displacement. Type 3, just posterior. So the inverse of type 1 is the type 3. One of the critical things with these OAD injuries is going to be all patients should be considered unstable because these ligamentous injuries are really difficult to heal, partly because of a low blood supply. And surgical and recovery from these, without surgery is often difficult. And one of the most important things with these patients truly is the initial management, right? So someone comes in with status post motor vehicle collision, maybe they have a couple cranial nerve palsies, cruciate paralysis, right? You look on the radiographs, you do some measurements, your powers ratio is 2 or 3, and so you're really concerned for an OAD. Right, so what do you do, right? What is the first thing you want to do? And in the past, they used to use this traction for patients with OAD. It's increasingly controversial. The whole reason they did that was to decompress kind of the nerves by just essentially trying to realign bony elements, particularly these type 1, type 3 trainalis fractures or dislocation types. But based on recent guidelines, right, managing acute cervical spinal injury, there's not really a huge benefit in doing this in terms of reducing neurological deterioration. So now it typically isn't recommended to go ahead and it is not recommended to use traction as a means to decompress neural elements acutely in these patients, right? But once again, these patients are considered unstable. They require surgical fixation. And one of the first things you want to do when you do make the diagnosis is place them in rigid cervical orthosis to promote distraction, place sandbags on either side of the head, and then tape the head down to the bed really to immobilize them. With these patients, dorsal fusion with rigid internal fixation that incorporates at least the occiput to C2 is required for adequate construct. Okay. And again, we got this down here just in the word format. Okay, so now we just move on to these occipital condyle fractures, first described by Bell in 1817. These are quite infrequent. They're estimated to be 1 to 3% frequency. Again, similar to OAD, common mechanism is going to be motor vehicle collisions, high velocity traumas. Anderson and Montesano, these are the people that are going to be attributed with defining this classification system. So, they classified three types, similar to Trenalis, with type 1 being comminuted fracture of the occipital condyle, type 2 being an extension of the linear skull-base fracture involving the occipital condyle, and then type 3 being an avulsion fracture of the occipital condyle. Type 1 and 2 are stable, require external mobilization. Type 3s are unstable and require surgical fixation. And this is just speaking in generalities. I'm sure you can find some case reports, you can find some differences in opinions, but based on the aggregate literature, these are kind of the recommendations. Here's a great picture here. We see these type 1s, comminuted, many little broken bony structures there. Type 2, right, this is going to be the linear skull-base fracture up here that extends through the occipital condyle. And then we see the complete avulsion of the type 3. Okay. Again, for these typically non-operative treatment with external cervical immobilization, it is almost always going to be sufficient to promote bony healing or bony union or healing and recovery of cranial nerve deficit. You should always think, though, when you get these occipital condyle fractures, that you potentially have a concomitant occipital-atlantal dissociation and vice versa, given the similarities and the mechanisms of these two injuries. And we'll conclude here with kind of probably one of the most famous things and this is going to be the isolated atlas fractures, right? So atlas referring to the C1. So we talk about the isolated atlas fracture, the Jefferson fracture, first actually reported by Cooper in 1822, not Jefferson. The subsequent publication was from Jefferson in 1919, right? So he kind of gets all the credit here. Later reports by Segal and Associates and Shirk and Nicholson use the term Jefferson fracture to indicate a burst fracture of the atlas ring, right? So, credit to Jefferson here for not giving himself the name. But again, this is 1 to 2% of all spinal fractures, right? So it's not a great deal. Typically, these patients are managed with, minimal intervention, rigid cervical orthosis. One of the major concerns here that we're gonna get into a little bit is what's the integrity of the transverse ligament, and is there any concomitant occipital-atlantal dislocation that we need to be concerned about here? And then, similar to its counterparts, we talk about this Landel's and Van Pendegem classification introduced in 1988. Again, type 1, 2s, and 3s. Type 1 is pretty simple, isolated anterior or posterior arch. Type 2 combined anterior and posterior arch. So this is actually the classic Jefferson burst fracture here. So type 2s also will be known, as the burst fractures. Type 3 involvement of the lateral mass in either anterior or posterior arch. Here's a good picture, right? So we look at the type 1s. So right here in this panel A, we got just the posterior arch involved. B, we just got the anterior arch involved. And we look down here at the type 2s. Right, anterior posterior arch on the unilateral on the right side, and then kind of this cross right to left anterior posterior arch, and then type 3s. Here's like the lateral mass, and you can see that's clearly involved here in F and G, and then there's an extension in G back to the posterior arch, and then in F there's an extension up here to the anterior arch. One of the most quizzable things in all of neurosurgery would probably be the rule of Spence. And, a little bit about this is when we talk about the relevance of these C1 fractures and, deciding what we're going to do with them from a treatment standpoint, we want to talk about the integrity of the transverse ligament, right? And in 1970, prior to CTs, this guy, Spence, comes along and says, if we look at a more than a 6.9 millimeter lateral mass displacement of C1 over C2 on open mouth radiograph, this is highly suggestive of a ligament disruption, right? So this is effectively referred to the rule of Spence. You'll see this in Greenberg. You'll see this in all the textbooks, right? You'll hear it commonly talked about. You'll get asked about it. This is something that still lives on in the lore of neurosurgery, even though the utility of such is debated. About 1990, this guy Heller comes along, writes a paper, and says that actually we should we should adjust this number higher to 8.1 as a result of radiographic magnification factors and really the increased resolution of radiography over the years. Um, a 7 millimeter displacement is also cited in the literature being pretty common. So, really the number to know is typically 7. I believe that's what Greenberg has. Greenberg has 6.9 or 7. That's really the number that people will talk about when they talk about the ligament suspense. Really, it was in around 2000, Dickman and colleagues, they came along and said that, look, the MRI was a more sensitive indicator of transverse ligament integrity and disruption, and that the rule of Spence, paled in comparison to the use of MRI. And, by and large, MRI in today's day and age is typically used to classify ligamentous injuries. And so, looking at signal intensity in the ligament, loss of anatomic continuity, blood at the insertion site of the ligament, these are going to be more powerful than really powerful predictors of injury than the calculation of the rule of Spence. But again, a good thing to know, something you get asked about quite commonly as you go through your neurosurgical journey. Okay. Again, most of these can be handled non-operatively, right? So isolated non-displaced 1s and 2s can be treated with mobilization for 8 to 12 weeks. Similarly, type 2 fractures with an intact transverse ligament, right? 8 to 12 weeks of external mobilization. Again, so like we talked about, type 2 fractures, and now we have transverse ligament disruption. These are the ones that are going to be considered unstable, and these might end up needing surgical stabilization. So it's important to understand that the context really and how we frame C1 injuries is going to be with respect to transverse ligament, by and large to transverse ligament integrity, right? So understanding and how do we assess transverse ligament integrity, knowing the rule of Spence, knowing the history of the rule of Spence, where we are today with MRI is going to be critical in making clinical decision making regarding, am I going to take this to the OR or not? Okay, and really, here's my references. A lot of this work, a great resource I always recommend is going to Human and Win for all the big background information and the detailed historical accounts. Go to Greenberg to get the highlights. The Neurosurgical Atlas online is great for anatomy. You go to A&O Spine, they've got some great images. The Greenberg Rapid Review is a good one. There's a lot of images and videos on the Seattle Science Foundation, particularly for spine. So anytime we're talking about spine, I think the Seattle Science Foundation is going to be a great one to go to hear some amazing talks and to see some good video demonstrations. I think this in particular, this lecture right here is going to be a good one that'll get you through some consults and some overnight shifts on your neurosurgery clerkship and sub-internships and get you a couple of those classical PIMP questions correct. I think knowing these classifications is always high yield information to know, and it should always be readily available at your fingertips. And if you can kind of master these things and kind of understand the general understanding of what's stable, what's unstable at the cranio-vertebral junction, and then you can what do I need to take to the OR, what do I need to worry about, and start to frame that in your mind and have a good idea. It all starts to come together and make more sense, and you can be a little bit more effective and discerning with how you communicate information to people when they ask you about these things. But this is going to start kind of one of the first videos in my new series on the neurosurgery clerkship. I'm going to be going over high yield topics, going over kind of highlighting some of the PIMP questions you're going to get, highlighting information that might be helpful. And I think I'm going to try to do some research videos and all sorts of different stuff at the request of the viewers. So feel free to send me a request and tell me what you like, tell me what you don't like, and we'll continue on with these with our series on spinal traumas as a series here for the next couple of weeks, and kind of move on to some other cranial based topics. So with that being said, thanks for listening today. Like, subscribe, do whatever you need to do. Send this along to a friend, and I look forward to making some more of these videos for you all.